Hello friends, today we are going to discuss about the vestibular schwanoma, also called as the acoustic neuroma or the eighth nerve tumor. Okay, vestibular nerve is the eighth nerve, and the vestibular schwanoma arises from the Schwann cells of the vestibular or the eighth nerve. These Schwann cells are the myelin forming cells in the peripheral nervous system, while in the central nervous system we have the oligodendrocytes that form the myelin. Okay. The key features about the vestibular schwannoma are that it is a benign tumor and it is well encapsulated, and it is extremely slow growing tumor, and it originates from the Schwann cells of the inferior vestibular nerve. Previously it was thought to arise from the superior vestibular nerve, but now recent studies says that it predominantly arises from the Schwann cells of the inferior vestibular nerve, followed by the superior vestibular nerve, followed by the cochlear nerve. Okay, and it is the most common tumor of the cerebropontine angle. Okay, followed by the meningioma, followed by the congenital cholesteatoma. Okay, the patient present in the age group of 40 to 60 years. Okay. However, the patient can be affected as early as 20 to 30 years if the condition or the schwannoma is associated with the neurofibromatosis type 2, which is also called as the von Recklinghausen disease. Okay, and both male and female are equally affected, and it is the radio resistant tumor. Okay, and the earliest symptom which occur with the vestibular schwannoma is the unilateral sensorineural hearing loss. Okay, this unilateral hearing loss can become bilateral if it is associated with the neurofibromatosis type 2. Okay, and this unilateral sensorineural hearing loss is retrocochlear in origin. Okay. The early symptom is unilateral deafness, followed by the tinnitus, then followed by the other symptoms that are associated with the brainstem involvement and the cerebellum involvement. Okay, the earliest nerve to get involved is fifth nerve, followed by seventh nerve, and then followed by ninth and 10th nerve. And when the fifth or the trigeminal nerve gets involved, there is loss of corneal reflex, and patient can also have trigeminal neuralgia. Okay, and when the seventh nerve get involved, which is the facial nerve, the sensory fibers are first affected, followed by the motor fiber. And because of the involvement of the seventh nerve, the sensations in the posterior superior meatal wall of the external auditory canal decreases, and this sign is called as the Hazelberg sign. In the Hazelberg sign, there is a hypoesthesia of the posterior superior meatal wall of the external auditory canal, and there is also seen the Schreiber sign. In this sign there is decreased lacrimation. Okay, and also because of the involvement of the facial nerve, there is loss of taste sensation from the anterior 2/3 of the tongue, since facial nerve supplies the anterior 2/3 of the tongue. Okay, and one thing you have to know, because despite being the involvement of the seventh nerve, the complete facial nerve palsy is never seen in vestibular schwannoma. Okay, and when the ninth and 10th nerve gets involved, there can be palatal, pharyngeal or laryngeal paralysis. Okay, now we look at some histopath. In the histopathology, we can either see Antoni A pattern or the Antoni B pattern, or we can also see mixture of both. In the Antoni A pattern, there is tightly packed spindle-shaped cell with deeply stained nucleus, and these cells are called as Virchow body. Okay, and in the Antoni B, we find the loosely placed pleomorphic cells with vacuolation inside the cells. This is Antoni B pattern. Okay, now we see the investigations. And the investigation of choice for vestibular schwannoma is the gadolinium enhanced MRI. We can also do the CT scan if the lesion is more than 1.5 cm. However, CT scan cannot detect the intrameatal tumor. Okay, other tests which we can do our audiological testing, in which we find the retrocochlear hearing loss, the features of retrocochlear hearing loss. And the features of retrocochlear hearing loss are the RINI will be negative and the speech discrimination score will be poor, and there will be rollover phenomena. The rollover phenomena in this, when the other person uses the speech which is in very high intensity, and the patient with vestibular schwanoma cannot discriminate, or the discrimination of the speech becomes worsens when the high intensity speech is used by another person. And this phenomenon is called as the rollover phenomena. In the caloric test, there will be decreased response, and there is also stapedial reflux delay. In the BERA, we find that there is delay of more than 0.5 millisecond in wave 5. Okay. And the treatment part, the treatment of choice is surgery. There are 4 approaches for this surgery. One is retrosigmoidal approach, retrolabyrinthine approach, middle cranial fossa approach. But the most common approach which we use is the translabyrinthine approach for the surgery of the vestibular schwanoma. Then we do the radiostatic surgery, in which we use the gamma knife surgery, in which cobalt 60 used as the source of radiation. The advantage of using the gamma knife surgery is that there is very low morbidity or no morbidity, and the function of the 7th nerve is well preserved, and also the hearing is preserved. Then we do the cyber knife, which is a robotic surgery in which the computers are used to do the surgery. Now let's see the MCQ. The first MCQ is the most common CP angle tumors are. The options are acoustic neuroma, meningioma, cholesteatoma. If the question says the CP angle tumors are, then acoustic neuroma, meningioma, cholesteatoma, all of them are the CP angle tumors. The answer then will be all of the above. If it is a question is asked about the CP angle tumor, but the question is saying the most common CP angle tumor, then the answer will be acoustic neuroma. Acoustic neuroma form 80% of the cases of the CP angle tumor. Okay. So here the answer will be, right option will be acoustic neuroma, not all of the above. Okay. Then the acoustic neuroma causes, the options are retrocochlear deafness, cochlear deafness, or conductive deafness, or any of the above. I already explained you the acoustic neuroma causes the retrocochlear deafness. This is the right option. When the hair cell gets damaged, the deafness will be cochlear. But when the nerve fiber gets damaged, which is distal to the cochlea, there is retrocochlear deafness. And third MCQ is, in acoustic neuroma, all are seen except, let's see, there is loss of corneal reflex. Yes, this is true. There is tinnitus. Yes, this is true. There is facial palsy. No, facial palsy never seen in acoustic neuroma. Diplopia, yes, it can be seen. So the right option is facial palsy. Thank you. Keep smiling. Sorry friends, there is one correction. While I was discussing the investigation, in the investigation part, when I was telling you about the BERA, in the BERA I told you when there is delay of 0.5 second I told you, but actually when there is delay of more than 0.2 millisecond in wave 5, only then we suspect the acoustic neuroma. This is the correction, you should correct it. Thank you.